Hey, hello everyone. Uh, so today we're back to discuss borderline personality disorder. Borderline personality disorder. Personality disorders, which I've stressed in the past, is more a condition than a disorder, even though we call it, disorders. Condition meaning it's essentially a lifelong display of a certain personality effect being emotions, okay? Instead of a disorder which can be controlled. And, it'll wane throughout time, what we call, episodic, okay? So that's the difference between what I consider a condition and a disorder. Borderline personality disorder, or what we call BPD, it's consumed under the class B disorders, which is dramatic and erratic, in the DSM-5, Diagnostic and Statistical Manual of Mental Disorders, number 5. Now, if you remember from previous vlogs, there are 3 clusters. I got a little hot coffee, and hopefully I won't spill it on my shirt. So there are 3 clusters, A, B, and C, okay? Cluster A is referred to as the autocentric, and it focuses on paranoid, schizoid, and schizotypal type of conditions, okay? Now, cluster C, the cluster that we're in, is known, I'm sorry, we're in B. Cluster C, what we're in, is what we're not in. Cluster C, it's a little late at night, sorry, is known as the anxious fearful segment, and that has avoidant, dependent, and what we call OCPD, or obsessive compulsive personality disorder, these conditions. And of course, cluster B, which we're in, I'm gonna get this right, it has 4 disorders under its heading. The first is antisocial, if you remember, which we broke down into psychopathy and sociopathy and Machiavellianism. We sort of branched those under that antisocial. The second condition we looked at was narcissism, which was my last vlog. And today is the third condition, BPD, okay? Borderline personality disorder. And later we're going to finish up with cluster C with histrionic personality disorder, so, which I really, with BPD borderline, it was a major thesis for me in my master's. So, and, I've had patients that I've diagnosed with BPD. But histrionic is very, very interesting to me. So there are these 3 conditions. There are 3 conditions in both A and C, and 4 in cluster B, for a total of 10 personality disorders that's recognized by our Diagnostic and Statistical Manual for Mental Disorders, or what we call the DSM-5. Okay. The 3 clusters, ABC, and the 10 personality disorders are, of course, as I call them, personality conditions. So now, in keeping with the previous vlogs, I want to remind you, I'm going to first describe the condition, then talk about the etiology, or what we think causes said condition, and then finish up with a cursory discussion for treatment, okay? I got to keep my coffee over here because it's got a warmer right there. I'm not, for BPD, I'm not going to list the symptoms from the DSM-5 so much. But instead, what I'm going to do is I'm going to explain them in such a way that the viewer can better understand what it looks like out in everyday life as opposed to the clinical view, okay? Because you get to reading, and there's not symptoms, but if you get to read them, it's just very confusing. So I'm going to sort of give you that, what does it look like in real life situations, hopefully. Now, as always, I want to remind the audience Please do not view one of these vlogs and then begin to go out and diagnose others. Believe me, it won't go over well, okay? Typically, I do not tell the patient or client what I've written as a diagnosis. But I have discussed it with some at the end of our therapeutic time together upon discharge. But if asked, I will honestly answer if I think it is professionally okay to help clarify what is going on in treatment. Also, I need to remind everyone that each personality condition, each of the 10, must meet 6 basic constructs of criteria for a PC, personality condition, to exist. First, number 1, the condition must be markedly different from the normal behavior than society and cultural norms view as acceptable. An example is someone who continuously hoards, okay, may meet paranoid personality disorder. So we may see hoarding as a symptom, okay? Second, the personality condition must cause extreme distress in relationships, occupational or other social environs. Believe me, today's subject, BPD, will definitely meet the criteria for that, the second one. See, interpersonal relations are at the heart of this disorder. So and we'll see that later on. Now, third, for general criteria, the condition must remain pervasive and consistent across different domains and throughout time periods. That's basically what we define as personality. Okay. Fourth, we must be able to trace this condition back to childhood or adolescence. Now, for BPD, this could be a little difficult, but this can be viewed as having what we call an insecure attachment with their parents. And, I've got notes here to explain that a little bit later on. So the insecure attachment with their caregivers. This is done, I guess that's my dog there coming up, yeah. All right, come on up, guys. This is done by conducting what we call an adult attachment interview, an AI. So if you haven't seen my vlogs on attachment, please go back and view both of them, because childhood attachment, along with trauma, neglect, it plays a big role in the development of BPD. Now, moving right along. Fifth, number 5, the personality condition cannot be better explained with a behavioral disorder, such as bipolar or what we call unipolar mania, or maybe even an adjustment disorder. See, disorders, I got to be careful here. Disorders typically are not as enduring or as lifelong as a PC, and in some situations can be attenuated by pharmacological interventions. Okay, number 6, the last one. The PC cannot be associated with substance or some external, what we call perturbation, being perturbed, perturbation, like lead poisoning or toxic chemical ingestion, okay? Now, with this last one, though again, impulsivity, mainly abuse of alcohol and drugs, plays a role in borderline. Okay? So, let me check the notes here real quick. All right. So, what does BPD look like now? Borderline, when we say borderline personality disorder, is just what it implies. It's between the border of neurotic and psychotic behavior. Now, neurotic is a higher than normal anxiety level or a lower than normal depressive state. So just to understand it, because we have the anxiety, which is higher, but the depressive state is lower. So just explain that, okay? Man, it's good coffee. Neurotic is considered what we think just to the right of normal emotional states. We all have anxiety, stress, depressive funks, or emotionally dysregulated periods. But neuroses is thought to be more out of kilter than normal functioning, but not as extreme as psychoses. Now, psychotic is defined as hallucinogenic, delusional, or disorganized speech. Okay? It is a true break with reality. Hallucinogens are mainly hearing voices, but they're limited. We can have visions and taste, smells, or tactile perceptions. But, that's limited. Typically, we'll have the hearing of voices. Now, delusions are false or imagined beliefs. So, I think, and I act like I might be the king of England, right? So if I think that way and act that way, I'm delusional. Or maybe I believe I have or their supernatural forces are giving me certain motivations or feelings for certain behaviors, without the voices, okay? So that's delusional. It's without the voices, but I believe certain things. And then, of course, disorganized speech is just that, what we call a word salad, or someone who talks in rhymes. You can hear that. I've witnessed that. So borderline, it fits right in between. It is not neurotic, nor is it psychotic behavior, okay? So to explain that and get that sort of cleared up there. So now I'm going to go through some diagnostic criteria for BPD that you may either view in yourself or others. These are very specific criteria, and they must meet the 6 general criteria I mentioned earlier. After you probably view the vlogs on personality, you'll be able to cite all 6 like I can, just sort of off the top of your head. Okay, for specific, the DSM-5 lists nine criteria for BPD, and it requires 5 to make what we call a categorical diagnosis. So what I mean is 5 symptoms out of 9, and that person is put into a box. They're categorized in that way. So that's what we mean by a categorization of it. Like I said earlier, BPD, at the heart of it is attachment, especially insecure attachment to others, mainly the mate in adulthood. Now, earlier I said it goes back to childhood, which I'm going to explain during the pathology of it, the etiology, what causes it, okay? But I kind of want to share some things here with you that what kind of facts of it is. Now, women, they have what we call a 3-to-1 ratio of this diagnosis as compared to men. That's not saying men can't have it, but typically what we see in the clinical world is there's a 3-to-1 ratio of diagnoses of BPD for women as compared to men. men tend to receive the antisocial label in replacement of this condition. So they get the antisocial label. What's also interesting, this is viewed more so as what we call a white female personality condition. Okay, so non-Caucasian women very seldom receive this diagnosis. Now, there is no robust explanation for this, just speculation. So I'm not going to address that. So again, at the heart of BPD is what we call insecure attachment. Now, this insecure attachment is based upon fear and abnormal reactions for real, perceived, or imagined abandonment. So I said that slow so you can kind of get it. This insecure attachment is based upon the fear and abnormal reactions for real, perceived, or imagined abandonment. Okay. The person with BPD, deep down inside, they feel that they're unloved, unworthy, or not valued, and there's this slow burning implicit belief that no one truly accepts them. I read something really interesting today about it, but I didn't make a note to include it. But where that comes from childhood. Okay. So nobody accepts them, and it's not if their partner will leave, abandon them, but when is the shoe going to drop? Okay. All right. So I'm gonna back up here a little bit and explain abnormal reactions, what I said earlier, to real, perceived, or imagined abandonment. I think that's important. The abnormal. Well, we said the abnormal may come in three ways. Okay. Depending, I hope I explain this okay. Depending on their insecure attachment style. Excuse me. Now we've got what we call three insecure attachment styles. Okay. It's either what we call perceived, anxious, ambivalent. That's the first one. I'm sorry. Preoccupied. What am I? Preoccupied, anxious, ambivalent. Okay. That's the first insecure attachment style. The second one is what we call avoidant withdrawal. And then the third is this fearful, anxious, avoidant type of attachment. But I'm going to encourage you, please go back and review my vlogs on adult attachment. I get into it pretty deep, and I can talk several hours on it. But, real quick, I'm just going to give you a quick review. What we call preoccupied, anxious, ambivalent is when someone, I'm just going to describe it here, is real clingy and needy. But, at the same time, they have this paradoxical acceptance, discuss repertoire with their mate. It's strange, they'll accept, but then again, not too much longer, they have this discuss shunning type of repertoire with their mate. So that's why we're going to call it this preoccupied, anxious sort of way. They're going to need reassurance of the other's commitment, yet they become frustrated because in their heart of hearts, they do not truly believe the beneficent agenda of the other. Okay, so like I said, this is due in childhood. In childhood, the caregiver being inconsistent in their nurturing. Okay, um, we're going to see this with mothers. Well, I just say mothers here, but it can be fathers, whoever the main caregiver is, who suffer from, well, back up here. Fathers can't suffer from postpartum depression. That's what I'm. So yeah, we're going to see this in mothers with postpartum depression, and then in fathers that can have depressive type symptoms, or with a father to a major depressive disorder during the development of the child. Okay. Those with this attachment trait, now listen to this, they will tend to remark in passive aggressive ways about the other leaving or eventually finding somebody else better. It's very complicated and can leave the mate, the other person, feeling overwhelmed and exhausted, trying to meet the needs of those with BPD. Okay, the next one. Now I'm going to talk about, avoidant withdrawal. What it sounds like. They have prepared themselves psychologically for their amorous other to abandon them. So they will display a very segregated and distal relationship. We'll see this much more in men than women, the avoidant withdrawal style. Okay. They'll stay busy and oriented to things outside the relationship, avoiding the intimacy and sharing. They are protective and use what we call a prophylactic emotional barrier. So if and when the mate leaves, it's not as emotionally volatile for them, even though they're still experiencing a lot of anxiety and hardship. But this avoidant withdrawal, they're preparing themselves. Remember, I said it's not if the mate's going to leave, it's when. It's a matter of when the shoe's going to drop. Okay. And the last one here is what we call a disorganized, disoriented state during childhood. And this develops into what we call a fearful avoidant. And there's anxiety is all part of all three of these, okay? But it develops into this fearful avoidant approach to the relationship. What I mean by this is during childhood, this is sad, during childhood, the source of affection and their protection was also a source of fear and trepidation. All right? Think about a parent who the child wants to connect and love and be nurtured by. That parent is punitive and punishing. It can be perhaps excessive corporal punishment or very harsh and critical ways of the caregiver. So how this plays out in an adult relationship is it takes prompting and encouragement by the other to connect. There's always this encouragement by the other partner to have that person who is fearful avoidant to connect with them. They're reminding them that the fearful avoidant, that it's okay to open up and become vulnerable. Also, we'll see inappropriate jealousy or unfounded accusations about fidelity maybe used with those with borderline. So not so much from the avoidant withdrawal type, but with these last two, the fearful avoidant, or in the first one, the preoccupied, anxious, ambivalent type. So we'll see it be used from the people with borderline, and it's to drive a wedge in the relationship. It all goes back to feeling unworthy, non-validated, and unimportant during the developmental periods. Okay, so I hope I explained it okay. I really do. So, okay. So now I'm gonna give you some statistics here a little bit. Um, now by now you've probably guessed these relationships are fragile, and researchers they posit and they claim, they predict that 75% of marriages with someone having BPD is on the verge of failure or is failing. It seems those with BPD inadvertently or they implicitly sabotage a relationship. Now, I'm going to say it again. Those suffering from BPD, they will inadvertently or implicitly sabotage a relationship. They may go as far as to do something to end a relationship before the other. So, yeah, I've seen that. It's like this self-fulfilling prophecy. Just remember, the fear of abandonment and their abnormal reaction to either, like I said, real, perceived, or imagined separation is from childhood insecure attachment, which is, proliferated in approximately about 60% of the children. Okay, that's pretty high, right? Insecure attachment, about 60% of our kids. So that means 40% have secure attachment. Also, suicide is 20 times more likely than the general population. And 10% of those that suffer from BPD take their life. That's the highest suicide rate of all the 10 personalities, disorders. What we call non-suicidal self-injury, NSSI, is also a major part of this trait of this population, which I want to comment on later because when I get down to describing some of the symptoms. Okay. Now, about 4 to 6% of the population, they suffer from BPD. Of course, there are both ends of that spectrum of borderline, from mild to severe, and somewhere in between. Okay. Since it takes, this is really interesting here. Since it takes 5 criteria to correctly diagnose, and there are 9 total symptoms, right? This makes BPD one of the most manifold presenters, what we call a manifold presenter. We call it, actually, it's polythetic, meaning it has many, many themes. So symptomatically, it can appear in 256 different variations. Okay. So there was some statistics for those who like numbers. This is going to be a long vlog, so I'm sorry. I hope I can stay with it and not lose my mind, keep my train of thought. So these relationships are very intense and unstable, and there's this cycling of idolization and devaluing. You idolize, you devalue. Idolize, devalue. One moment the mate is a prince charming or a princess charming. and the next they are this anathema, this, they're pilloried, they're placed in stocks, in these emotional stocks for punishment or for psychological torture. Remember that ambivalent state in childhood? It plays out this way in adulthood. So ambivalence, you don't know either side. You're ambivalent about it, right? So You idolize, devalue, okay? And this causes the other mate, they don't know where they truly stand. You may also see this kind of cyclical behavior, and it's just not mates now, in friends, coworkers, or a boss. So one minute, you're better than sliced bread, and the next you're like this scum or fecal matter on the bottom of their shoe. So that's what we call idolization and evaluation. So that's the first one. Okay. The second, of course, I'm not giving them to you out of the DSM-5. I want to kind of describe to you what it looks like, because if you read them, you kind of, you really won't understand them. So the second one, now this one, to me, is really, really the big marker for BPD, and that is lability. Okay. Now, I'm not saying liability, but lability, labile. Okay. What lability is, it's an intense episodic instability of affective states. Their emotional states switch in this episodic fashion. It can be from happy to sad, from angry to forgiving, from connected and involved to unconcerned and distal. Okay, so you can think about that person with avoidant withdrawal. This, they're involved, and then boom, they're unconcerned and distal, right? Now they may do this rather quickly, and you can see it quickly. Like in session, I might see it within an hour. But at work or home, it may be a day-to-day cyclical pattern. So typically, we gotta wait and see. We might say we gotta wait and see what kind of mood mom is in, what kind of mood is dad in. How's the boss feeling today? That is pretty much lability. Okay. This unpredictability of effect from those with BPD. Now, listening to this, you may have guessed this plays into the previous criteria of idolization and evaluation. See, they both cycle and connect. Okay? So they may overlap each other. I'm going to be careful here, but I'm going to say something. If you know someone who's a busybody, like a friend, someone who's always snooping or involved in an intrusive fashion, with others, and they overly criticize or devalue others, there's an approximate chance that they can have traits of BPD. Okay, I'm not saying they have it, but this is a trait. So to your dismay, what they're doing is they're idolizing you when you're together, but with others, chances are, you are the subject of critical assessment. That's what we call a preoccupied state from childhood, trying to allay the anxiety and ambivalent feelings they implicitly feel. Now, I want to say the slam dunk for me are these three symptoms that I've given you. Okay, so the first one is they have this abnormal reaction to real, perceived, or imagined abandonment, right? The second one, it's this pattern of idolization and devaluing. So that's very important when you see that. And the third one is going to be the lability of it. Okay, this switching. To me, that is the core of borderline personality condition. drinking coffee at 9:30 at night. How's that going to turn out, Mick? Okay. Now, another fairly obvious symptom or criteria for BPD is what I'd mentioned earlier, is what we call NSSI, non-suicidal self-injury. What we see is cutting, burning, hair pulling. We call this trichotillomania. And, skin picking. Pick their skin. You can see scabs on them, and it's what we call excoriation type stuff. Now, you'll see that too with people who abuse methamphetamine, because the sensation it gives in their skin, it feels like, they feel like they have bugs under there, okay? So just because you see somebody with this skin excoriation on their forearms, don't think, oh, they've got borderline personality disorder. It's also a trait we see with amphetamine abuse, okay? Now, one of the first things that I do during what we call this an MSE is a mental status evaluation, a mental state evaluation, and this typically takes place in the first session. Is I ask to look at the client's legs or arms. If I see some type of self-inflicted wounds, there could be like tattoos trying to cover it, or some wearing of long sleeves or long pants when it's not climate appropriate, so that trying to cover up the injuries, okay? I had a client who would use X-Acto knives, those real sharp razor knives, to make very small cuts on her body. And then with these open wounds, she would take a bath in bleach water. Yeah. So, even the continuous biting of nails down to the quit causing pain. So it's a way of them to release their anxiety, to understand that, okay? Now, there are also sometimes parasuicidal behaviors. And these are like, fainting suicide by accident. Typically don't cause death or threats of killing themselves. Now, of course, I'm not minimizing this, okay? This takes priority in session. Because remember, the statistical weight is very pronounced, what I told you about. And, more so than any other personality disorder, okay? And 10% of those diagnosed with borderline in their lives. So this is a very serious conversation, and anyone in their lives, any brother, sister, mother, husband, anybody, they need to take the appropriate steps to notify the proper people who can intervene. Now, I'd really like to discuss the signs of suicide and what to do as a layperson, but I'm gonna make a note to do that as a special vlog on that subject, okay? But I just want to stress that the two big red flags here for suicide, for successful suicide, are previous attempts and a plan with means to carry out suicide. So if I have a patient who has had previous attempts, he or she tells me, or it's in their chart, and I learn that they have a plan with means to carry out that suicide, that is big time alarm bells, for me. And, and I think it's okay to be blunt and ask them specifically if they want or plan to kill themselves. Just remember that, ask pointedly, right? Do you plan to kill yourself or commit suicide? It's been shown those questions will not trigger a behavior. They actually want to talk to someone who will just listen. Okay. So, I kind of got off on suicide there. Okay, dokes. All right. Now, this next behavior is what we call impulsive acts. Now, impulsivity in the clinical realm is different than our everyday vernacular. So it's different from how we use it. So it's not so much spur of the moment behavior like we think of in our everyday vernacular, but it's something a person does to themselves knowing it is unhealthy or it is physically dangerous. That's what we consider impulsive. The abuse of alcohol or drugs, binge eating, excessive spending, which leads to insurmountable debt, reckless acts like driving, diving, swimming, or even reckless behaviors where I'm at here in Northeast Alabama. This reckless behavior on ATVs or etc. Okay, it's like whatever they do, it's on the edge of dangerous, or it's seriously unhealthy, or like mixing drugs and alcohol. Okay, I wish I didn't need reading glasses, but hey, it's age stuff, good stuff. All right, so far I've described 5 symptoms or criteria. Okay, so which I think are easier to see or witness for a typical person not trained in mental health. I'm gonna cover them real quick. And all right, number 1 is abnormal reactions to real, perceived, or imagined abandonment. They feel like the other person is going to leave. Okay, it's not a matter of if but when. And you'll see passive aggressive things. They'll say, "But you can find somebody better," those sort of things. Okay. The second one, unstable and intense personal relationships that use this cyclical this idolization and devaluing. Okay. Number 3, and I'm probably not going to get these in order like I've mentioned them. So it's coming to the top of my head here. NSSI, non-suicidal self-injury, which are recurrent self-harming, mutilating behaviors, okay? Plus these parasuicidal acts. Intense, episodic, affective instability, right? What are you saying? What we call lability. They have this cycling of emotions, lability, okay? And number 5 is self-damaging impulsive acts. Now we have 4 more symptoms left. So beyond these 5, we can kind of sometimes anger. We can include anger. Number 6, that's kind of disproportionate to the situation. This is what I call the telltale symptom, because it'll cross over to other conditions or disorders. So it's sort of hard to attach to BPD, but it's there sometimes. So, if I get that, then it might just, I might get 3 or 4 and then get an angry outburst and things that's disproportionate to the situation. Okay. But, yes, this uncontrolled anger or difficulty controlling anger, which is frequent, where someone can, where you can spot, where someone else can spot a pattern over time, can be used as a defining criteria. So I see this as an additive symptom. It's there, it's listed. But like I said, it can lead to other conditions or other disorders, like we see. It's kind of like for me, it's kind of like the straw that broke the camel's back, so to speak, for diagnosing. but it's kind of this general criteria because everybody has anger issues and we may misread those, but clinically we know how to read this anger, which is disproportionate to the situation. But when we couple this with 3 or 4 of the previously mentioned symptoms, it can help solidify that diagnosis. So I wanted to slip that in there about anger. Okay, now there are 3 more. And these are what I call Barnum symptoms, okay? If you've ever had an introductory psychology class, you should have learned about P.T. Barnum of the famous Ringling Brothers and Barnum and Bailey Circus. Okay. What he did is he's generalized his language and approach. And he's a salesman, is what he was. So he generalized his whole language and approach so it would just about match anybody. I think a good example of this are like fortunes. They're written so they can fit just about anybody. They're this whole generalized sort of way. So these last 3, which I kind of see as Barnum kind of symptoms. I don't know if anybody else calls them that as a psychologist or a counselor. So the last 3. Okay. I want to get these because they're generalized and I want to kind of get them right in my mind here. All right. So a chronic and complex sense of loneliness. Okay. See, I can fit a lot of people that can have depression. The second one, unstable self-image causing an identity disturbance. So somebody with low self-esteem, they may not have BPD, they just have low self-esteem. And the last one, number 3, which is number 9, is this paranoia type of disassociation that is transient or episodic, meaning, they get, I haven't talked about disassociation before, but it's this sort of disconnection. Remember I said it was between psychotic and neurotic, and I talked about, hallucinogenic and psychotic is this break from reality. So when we look at this, it's this paranoia type of disassociation. That break from reality is disassociation. Now, daydreaming is dissociative, behavior. So don't get a little too wound up in that. But it's transient or episodic, so it's not there all the time. So they're not psychotic. Remember, borderline fits in the middle, neurotic, borderline, psychotic. Okay. So that paranoid sort of disassociation, that's you or me at times. So that's why I label those as Barnum criteria. And it really takes a trained and skilled clinician to really ground those down into more specific, behaviors. So I got a lot of notes here. So hang with me. You can always just, shut it off halfway or whatever. Because I don't know how long it's going to be. And, I've been wanting to do this for a while. So I really like to study my notes a lot before, when I get in so I can talk a little freer and not have to, look at stuff. So, we've covered a lot. And now I'm going to switch over to the etiology in treatment. So etiology, where's it come from, what causes it, and then get into treatment a little bit, okay? So, Nancy McWilliams. She's one of my favorite authors. I just love reading her. She explains that BPD is this perfect storm, tying together what we call nature and nurture. So if you've had psychology have heard of nature nurture. Nature being our genetics and the expression of our genes biologically through our endocrine system, our neurological makeup, and other ancillary systems like our immune system. Okay, and nurture being how our world, our family life, our peers, or school, or just life in general, how does it treat us? How does it cause us to develop? Excuse me. During early childhood, oh, got gas. During early childhood, all this comes, it all comes together in this cauldron of temperament or temperament. Okay, I've never talked about temperament. I'd really like to. It's really interesting. I love personality and how it develops, but it comes this cauldron of temperament and personality development and emotional regulation and societal factors, which it all gets mixed with this insecure attachment styles of what I mentioned earlier. The preoccupied, anxious, ambivalent, the avoidant withdrawal, or the fearful avoidant, which comes from, I don't want to confuse you because you have childhood labels and then adult labels, but this fearful avoidant comes from this disorganized and disoriented childhood. So, these responses, they're heated over a flame of just childhood maltreatment, such as abuse, neglect, lack of affirmation. Okay, think of that one, lack of affirmation, and or just dysfunctional bonding. I don't know this. I looked here at this. I don't know how they came up with these figures, but researchers think that BPD is 42% biological and 58% environmental. So it's more nurture than it is nature, right? Okay. So there's more outside influence and inside influence. Genetically speaking, and this is my concentration is neurological, behavioral psychology, but genetically speaking, what we have is we have the serotonin and dopaminergic chromosomes, 5, 9, and 11. They have what we call these polymorphisms. Okay. So polymorphisms, meaning several differences. A morphism is a difference, and poly means several or many. Compared to what we call healthy controls. These polymorphisms are either unless you know some about genetics, they're either what we call short long alleles or short alleles. Now, hopefully, one of these days I'll do something on genetics. I love it, and these either short long allele or short alleles, they cause these inhibitory problems, these attachment issues, and these behavioral manifestations, which disrupt interpersonal relationships. Okay, so in a nature sort of way, they've said that 5, 9, and 11 on these chromosomes, there's some differences. These polymorphisms compared to normal. What we call a long allele. Excuse me. So, like I said, they cause inhibitory problems and attachment issues. So, in a way, they just really can't help, what's happening to an extent, right? Because their brain is wired, and I love talking about the brain. I'll do some deeper things later on. Is wired in a more sensitive nature, and the person will they'll then use what we call defensive mechanisms to cope with life. denial, projection, displacement, and what I was earlier, I said I was reading something today I didn't write down. Introjection. They'll interject that caregiver, that I'm no good, I'm unworthy, I'm unloved type of care. They'll interject that caregiver into them. So interjection is also a defensive mechanism. When we say defensive mechanisms, we're talking about maladaptive type of ways where coping mechanisms are more healthy. Okay, so we got denial, projection, displacement, introjection, and other less mature coping mechanisms. Also, during early development, like the first 2 years, your brain grows 122%. So, but that's not what I was going to say. Popped in my mind. So everyone's right cerebral cortex is undergoing this massive growth and synaptic connection, along with the limbic regions, which are really deep inside the recesses of our brains. These are getting wired up. What we call this synaptic connection. So our right side and our limbic regions, those are emotional areas for implicit memory and automatic behaviors. Your implicit memory, your emotional memory is here on the right side because it develops first, and you don't have language prior to 3, so you're going to have emotional memory stored on the right side, and also deep in the recesses in our limbic region. So they're going to get wired up, okay? They get wired up first. And with insecure parental caregiver, that the attachment, the right side, does not form in healthy ways. And that, I'm sorry, but that stays throughout a lifetime. Plus the amygdala and the hypothalamus, they become very sensitive in nature, which can overwhelm our coping abilities, So we use defensive mechanisms to help that. Denial, projection, displacement, introjection. So our right hemisphere is emotionally the stunning, and that will cause a lesser amount of good chemicals like vasopressin, oxytocin. These are neurochemicals which help humans connect and bond. And, the limbic system is hypersensitive to interpersonal bonding, interpersonal between two people, I-N-T-E-R, personal, interpersonal bonding. I had a previous patient, and so she had what I felt like was a dearth, not a whole, below normal standard of neurotransmitters, the vasopressin, oxytocin, the endogenous opiates, which caused her to seek out external chemicals. These external chemicals were heroin and ecstasy to balance herself. And I think I discussed this in my vlog on addictions, why people use. They try to balance themselves because they have this imbalance of neurochemicals in their brain. That's just that's why they get addicted, what we call addicted. Okay. So these internal opioids, it's what I call the godfather of the 9 basic neurotransmitters. We have so many, but there are basically 9 basic neurotransmitters. And these 9, they have this backdoor modulation in some cases. And so being sexually abused and rejected as a child, as early, I'm talking about my patient, as early as she could remember, her brain did not successfully connect and provide adequate chemicals to ensure normal human connection. When it's normal, the brain's going to wire up normally. When it's abnormal, the brain's going to wire up abnormally. Hibbean rule. So, and I remember she remarked that, she had this inability to feel, to love, even with her own daughter. Okay. Okay. Sometimes I get, a little bit on a tangent. Okay. Hey, treatment. So treatment is very specific. If someone with suffering from BPD is fortunate enough to find a team treatment paradigm, that is by far the best. Okay, it's called dialectical behavior therapy. Dialectic behavioral therapy. DBT. Right, and we got BPD. Right. So, what a dialectic is, it's these two competing ideas or issues that seem to be polarized. I guess the real simple analogy is like one side is black and the other side is white. What occurs is the individual learns how to meld these two views into a gray, or just accept them for what they are. Two competing views, right? Now, as a Christian counselor, I'm not talking specifically about morals or values, but life concerns that are at polar ends. I guess an example of this might be, you think it's necessary, or somebody might think it's necessary to think in absolute terms. Only there's only right and wrong, what we call splitting. And they will choose this way over that. So, like I said, it's called splitting, and it's a defensive mechanism we see in BPD, splitting. Black, white, right, wrong, splitting. Is one side or the other? Good, bad. There's no in between. So people with BPD have trouble with ambiguity, which is accepting, there may be no real answer, or there may be a neutrality between 2 points. This is known as dialectics. Just living and accepting, these conflicting sides, okay? Now, since I'm a one-man show, and I can't use the formal version of dialectical behavior therapy, because it really takes a team, I use this approach. It's a psychodynamic approach. It's coupled with what we call interpersonal neurobiological theory. I educate a lot what goes on in the brain. And I know it's 58%, environment, but believe it or not, environment wires up the brain, what we call epigenetics, but I'm not going to get into that because I've already talked about etiology. But so, yeah, I'll use this interpersonal neurobiological theory and also sensory motor theory. Where does it, where can you feel it in your body? What we call, and then also I'll use internal family theory. Because the family's involved because you're growing up. So we got to bring that in. That's psychodynamic, very much because we look in the past. And I'm going to use this schema therapy with that. These schematics we do. And, this is what we call a cognitive behavioral sort of approach, because that's what schemas do. Schemas are automatic. And that's what CBT looks at. And also with CBT, I'll for behavioral things, behavioral parts. Okay. So I'm going to explain these kind of real quick here to you again. So psychodynamic, it peers into the past, and we bring out that out in ways, that schemas were developed. So I'm going to kind of connect these here. So we go psychodynamic, we go in the past, some things we look at, we talk about, we feel, this emotional. We can't really get too emotionally connected because remember I told you the lability of the person with BPD. We got to be very, very careful with that, especially if there's been a lot of abuse and we may have some disassociation. And I'm not saying multi-personality type things. It could be there, So you got to be really careful with the, how we get emotionally connected and going in the past. But we want to look at ways these schemas were developed. Now, when I say schema, think of a schematic, a blueprint for how something works. In schema therapy, we lay down this blueprint for interpreting and interacting in life in an automatic and implicit sense. So, we're basically back in time discovering our automatic ways of thinking, feeling, behaving. By possibly what may have happened are those things that we missed, out on because loss. If you don't have a normal development, that's loss. Okay? And I stress this. If you get sexually abused, if you're punished all the time, if you're not nurtured and hugged and loved, that's loss. Okay? So, we're going to learn how that ways of thinking, feeling, behaving. And when I do the interfamily or what we call internal family systems, it brings the characters in our world, both past and present, there. Then, we're going to learn how our brain develops and, how that impacts today. It seems to be very eye-opening for many. We really think, we're, believe it or not, when I get in and start talking about conscious, unconscious, and all that stuff, we really think that, consciously we're in control when only 5% of our brain activity is what we call conscious or explicit. Now, I'm not going to get, way in that, but that's just 95% of what our brain does is in a non-conscious or in a pre-conscious state. Then, the sensory motor, we're going to start sort of exploring the body for where those implicit memories are stored. But here's the deal. Stress, anxiety, trauma, it's all our energy. And to understand it, energy needs to be exhausted. It needs to be used. If that doesn't happen, then our body stores it, okay? So sensory motor looks at that, and it's used to expel this stored toxic energy. There's ways we go about doing that. From a psychodynamic, it's what we call or refer to as cathexis or catharsis. What happens is a counselor and a client, we bond, this interpersonal bonding in this healthy, secure attachment way. And I use these aforementioned therapies to heal. Now, it takes a very, very long time, usually longer than 2 years, depending on the severity of the BPD. As you can imagine, this treatment is difficult for both the patient and therapist. It's common to have ruptures in the therapeutic relationship. But what's important is a counselor models, how to patch these ruptures. Like in a secure attachment where the child and caregiver, they had a rupture, then mommy comes and soothes the child, okay? And the child learns how to self-soothe. So, this is sort of the vis-a-vis, this is what should have happened during development. So, during treatment, neurological synaptic connections, what we call synaptogenesis, it does occur, and the brain does change. So, I told you earlier that, there's no change, or yes, there is change, okay, when it's done correctly. Also, neurogenesis in the hippocampi. This occurs laying down new and stronger emotional regulating connections. So the brain is actually wiring up this within the hippocampi. It's actually neurogenesis. We're growing cells, but also our synaptogenesis, our synapses are becoming stronger. Okay. So this all what it helps to do, it helps to sort of down-regulate what we call the hypothalamic pituitary adrenal axis. So it'll down-regulate the lability. It down-regulates the idolization, devaluation. Okay. It down-regulates the impulsivity and use of substances. There's hope. And there's a treatment for BPD, yet it's a personality condition. And these remnants do remain. There's remnants remain of the old ways, but with thought and practice, these firings can be attenuated to where they're not the automatic course. Okay. So now this has been long. So I love this personality disorder. This and histrionic. There's a lot. Histrionic is what we call BPD light, and I may see a lot more of that than I do PPD. But I hope you've enjoyed this. As always, you can reach out to me for any need. Private message me on Facebook or email me at agapecounselor@outlook.com, or give me a call 256-599-0291. And next time we're doing histrionic, okay? And hopefully I will not be as long in between. All right. God bless you. Until next time. Maranatha.